Hi guys, Dr. Gillard here. It's GIGU. We're going to start talking about, or we're going to finish up Crohn's disease today, and then we're going to just start talking about ulcerative colitis. So that's where we're going. It's Tuesday, it's spring of 2021, it's week 10, off we go. So where have we been so far? Let's do a little recap of Crohn's disease. It is a member of the inflammatory bowel disease group, just like ulcerative colitis. It tends to present with patterns of flare-ups and then remission. So horrible diarrhea and abdominal pain, and then you feel better. Then it hits again, and then it doesn't always. Some people have it all the time, as we'll see. It involves, histologically speaking, it involves the entire wall of the small bowel, or it could hit the large bowel as well. So it's a full thickness or intramural inflammation. It classically skips around, so it can hit the proximal ileum, and then the distal ileum, and then the proximal colon. So those are called skip lesions. The symptoms, the flare-up, we said the symptoms are typically severe abdominal pain with diarrhea are classic. Not so much bleeding. Ulcerative colitis, as we'll learn, is more associated with rectal bleeding. And of course, it can be associated with extraintestinal manifestations, such as, which is called enteropathic arthritis, which we saw examples of that, how it can destroy the knees and the ankles and the SI joints. Remember, enteropathic arthritis, sometimes it's called enteropathic arthropathy, is one of the seronegative spondyloarthropathies. So what are some of the late stage findings that you would see with endoscope and histological analysis? Large aphthous ulcers. We said one of the earliest signs of these are aphthous ulcers, which are canker sores in the affected region of the intestine. But later on in the disease, through the process of ulcers and healing and ulcers and healing and over, you can start to get a cobblestone appearance. You can also start to get sinus tract infections within the intestinal wall, kind of like an ant farm, if you've ever seen one of those, how there's the ants dig little tunnels all through the dirt that's pressed between two pieces of glass. Same kind of deal. Those are called sinus tracts, and you can get those through the infected intestine as well. And yeah, sometimes they can go right into organs, and they can become really problematic. And even if you have it in the rectal region, it can come right out into the visible, onto the surface of the skin. You can get fistulas. The inflamed areas can touch a good piece of intestine, and you can develop a hole, which is a fistula, or even it can touch, like say, the gallbladder, and you can get a fistula between the intestine and the gallbladder. And then you can get adhesions, interluminal adhesions, so scar tissue on the inside of the affected part of the intestine, which makes it difficult for fecal material to pass through, and it can result in small bowel obstruction or even large bowel obstruction. Here's a little cartoon. You can see the sinus infections here. So bacteria have superhighways. Some of these could go to the side, and we could expand on this drawing a little bit. Now, I guess I didn't turn on my drawing tools, but they could be everywhere, like an ant farm in here. Another phenomenon is called fat wrapping. So this is interesting. So because of the full thickness inflammation of the bowel, some of the fat, the mesenteric fat that's out in the peritoneal cavity, it can help. It can come in, the fat cells can invade the intestine and try to help snuff out the inflammation. And the intestine can become wrapped in fat, which is basically thousands and millions of adipocytes trying to help fight the infection. That's called fat wrapping. So here is a normal intestine on the left, and on the right we see one that is fat wrapped. from fat trying to help snuff out the inflammation. We can see a fistula there as well. What causes this scar tissue to build up in the lumen of the intestine? Well, in the inflammatory phenomenon that occurs via Crohn's disease, there's one interesting thing that typically happens. You get a overproduction of tumor necrosis factor beta, and that's the one that calls in fibroblasts. So in other words, you get a fibroblast heavy inflammatory in process. And fibroblasts make type 3 collagen, which is good for fixing aphthous ulcers. But if you have too much of it, it can cause all sorts of trouble and scar up the inside of the intestine. And that's caused by macrophages that come into the area. So yeah, normally type 3 intestine repairs aphthous ulcers, but it gets wildly overproduced in some patients with Crohn's disease. And therefore you have a fibroblast heavy inflammatory condition, and it can result in this. There's just tons of scar tissue in this intestine, and it could be very difficult for fecal material to try to move through that, and can get stuck and cause a small bowel obstruction. Here is some imaging showing that the intestine, the lumen, is narrowed down to nothing because it's filled up with scar tissue. This section was removed in a patient with Crohn's disease, and the intestine is filled with fat wrapping, chronic late complication of Crohn's disease. What are the patient's symptoms? What kind of symptoms do patients with Crohn's disease have? Well, we already said the big ones are diarrhea and abdominal pain. But they can also, if it's a bad infection and inflammation, you can start getting feverish and flu-like symptoms, malaise, no energy, fever, joint and muscle pain. Now that could be just from the flu-like symptoms, or that could be a sign of extraintestinal involvement. But the big three, of course, are diarrhea and abdominal pain. And then you don't want to eat when you're having these flare-ups, so you get weight loss and malnutrition. What causes the symptoms? Well, there's nociceptors in the intestinal wall, right? There's pain triggers, and they can be set off by the inflammation, by ulcer formation, by fistula formation, or stretch response secondary to intestinal obstruction. Another new word for you, or this is probably a new word for you, tenesmus. So rectal tenesmus is a problem with Crohn's disease. So tenesmus is a feeling that you have to go to the bathroom, you have to sit on the toilet, and you feel like you have to defecate, but you can't. And you sit there for an hour, and you can't defecate, and maybe a tiny bit will come out, but that's tenesmus. Specifically, it's called rectal tenesmus, and that's classic of Crohn's disease. There's a vesicular tenesmus, where people strain and strain, they feel like they have to urinate, and that's patients maybe with severe BPH could have something like that. For Crohn's disease, you'll have rectal tenesmus is a symptom, so make sure you know that word. It can occur in patients. Tenesmus is actually more common in patients with ulcerative colitis. It can occur Crohn's disease, but much more common in ulcerative colitis. Well, we said that one of the favorite spots for Crohn's disease to hit is the distal ileum, and that's where the cubolin receptors are, the CBAM receptors. And if we inflame those and destroy them, then you can't bind intrinsic factor vitamin B12 complex, and therefore your vitamin B12 is going to go right out in the fecal material, and you're going to be short on vitamin B12. So you could develop pernicious anemia, or megaloblastic anemia is the giant category, but it's a vitamin B12 deficiency you would develop because of that. Intestinal symptoms, yeah, you can have intestinal pain. Maybe because of the stenosis, probably because of the inflammation in the wall of the intestine is setting off the nociceptors and causing pain. But yeah, you can have all those things. If you get intestinal obstruction, though, then you can have all those symptoms, including the throwing up of bile, colicky, crescendo, decrescendo pain, dehydration. Yeah. What about blood leak? Well, it can happen in Crohn's disease. Patients can have hematochezia or blood coming out in the stool, or even melena, but it's not the rule. Ulcerative colitis patients have much more blood leak or hematochezia, fresh red blood coming out of the fecal material, or melena is a dark tarry blood, depending on which region of the bowel is affected. Fecal occult blood may be positive, so some of this full thickness intestinal wall inflammation may be leaking a little blood into the intestine, so it could be picked up by fecal occult blood test. Typically no melena or hematochezia. Gross picture warning. And so diarrhea, again, is one of the most common symptoms. Why do people with Crohn's disease have diarrhea? Well, just like any inflammation process of the enterocytes, which normally reabsorb water like crazy, especially the intestinal enterocytes, if they're inflamed and upset, they stop doing their job, and so you can't reabsorb intestinal water, and therefore your fecal material has way too much water in it, and that's basically the definition of diarrhea. How about some differential diagnoses? Well, we know one right off the bat is ulcerative colitis. Can be difficult to tell Crohn's disease from ulcerative colitis. They're both inflammatory bowel diseases. Irritable bowel syndrome is another one. Any of the gastropathies or gastritises that we've talked about, the non-atrophic and the atrophic and the chemical gastritises, all of those can cause our differential diagnoses, because Crohn's disease causes abdominal pain, and those cause abdominal pain. Usually it's more stomach-like pain, but differential diagnosis. Amyloidosis, cancer, gastroenteritis is a strong differential diagnosis. That's not going to be chronic probably, though. A diverticular disease could be in there. Vascular disorders could be in there as well. There's polyarthritis nodosa again. I'm going to put those slides. I think I talked about that one time. It's a type 3 hypersensitivity reaction. It's almost 100% fatal if it's not treated. Treatment of Crohn's disease. So how do you treat this? What's the cure for Crohn's disease? There is no cure. The best you can do is fight the symptoms of it and try to get it into remission and try to keep it in remission. So what's the definition of remission? Well, no more patient symptoms, and then you go down with an endoscope or a capsule endoscopy and look. And if all the aphthous ulcers are healed and no more oozing, then you're in remission. And now the job is to keep you in remission. Back to a flare-up. What foods? I like this slide. There's definitely a question on the test. I mean, you'll probably get this more in nutrition, but I'm not sure if you will or not. So what foods can you advise your patient who's having a flare-up of Crohn's not to eat? Anything that's hard to digest. So all the insoluble fiber foods, the fruits, at least the skins of fruits and seeds and raw vegetable, broccoli, cauliflower, raw nuts, whole milk or whole grain. Whole milk as well, dairy, sugary foods, alcohol, fatty foods. Those will precipitate and persist, make the flare-up more persistent. What about safe foods? Just the opposite. Low fiber foods like bananas, a honeydew melon, fully cooked, skinless vegetables, asparagus tips, cucumbers, potatoes, refined grain, oatmeal, white rice, pasta, white pasta, sourdough, potato bread, and lean proteins, fish, lean pork, white chicken, and eggs. Should be safe to eat. What kind of medications are these patients on? Well, they're on anti-rheumatic type drugs, sulfasalazine. I used to have a big long section in here about medications. It's just got too much, so I do have older videos on YouTube if you want to get into the medications, but that's not our primary goal, right, as chiropractors. We should know a little bit about it. So sulfasalazine has been around forever. It's an anti-rheumatic drug. Antibiotics, because there's almost always going to be an infection associated with this. Glucocorticoids to help snuff out the inflammation. And then immunosuppressants, because there's indications that Crohn's disease has an autoimmune component to it, and overactive immune system needs to be calmed down a little bit. All right, let's just start ulcerative colitis, and then we'll call it a day. So that's the other member of the inflammatory bowel groups. Only affects the large intestine. There's no skip lesions. It doesn't affect anything except the large intestine. What's the difference between ulcerative colitis and Crohn's disease? Ulcerative colitis is more common in adults. Ulcerative colitis does not have skip lesions, and so it doesn't strike discontinuously. It only affects the colon typically. Unlike Crohn's disease, ulcerative colitis does not typically present as a transmural inflammation, so the entire wall is not affected. Just the mucosal layer is usually affected. I should say too, I could have added that ulcerative colitis bleeds a lot more than Crohn's disease, so hematochezia is much more common in ulcerative colitis compared to Crohn's disease. At present, the etiology is still unknown with regard to causation of this, but just like Crohn's disease, ulcerative colitis is thought to be secondary to a bunch of kind of a combination of problems with genetics, immunology, like a rheumatoid or like a autoimmune kind of component to it, and environmental factors. Just like Crohn's disease, it can present with extraintestinal manifestations, but not nearly as often as people with Crohn's disease have much more trouble with extraintestinal manifestations and enteropathic arthritis. The disease can cause significant morbidity and mortality even in people. In fact, up to 33% of those affected will eventually have a colectomy. So the disease-affected part of the colon just flat out has to be taken out surgically. It's so inflamed. Significant advances have been made regarding this disease. Yes. Epidemiology. Its incidence and prevalence varies greatly over geographic location. Prevalence is about 0.25% in the West. Crohn's disease also has a north-south gradient, so people who are closer to the equator and get more sunlight-created vitamin D seem to be somewhat protected against this. A recent systematic review demonstrated the incidence and the prevalence are increasing worldwide. So we're not sure why. It's probably something in the environment that is setting this off that we haven't figured out yet. People of Jewish ancestry are more at risk for Crohn's disease and ulcerative colitis. And Crohn's and ulcerative colitis are a major drain on the economy. 2009, more than almost $5 billion. I'm sure that number is probably $10 billion by the 1920s, or the 1920s. The 2020s, 2021s. The natural history, so what's the story with this one? About 85% of patients will suffer repeated lifelong flare-ups. So you get one flare-up when you're a teenager, and most of you will be in the club, so to speak. The flare-ups can be followed by long periods of remission, which is good and hopeful, but it's not the norm. The probability of remaining in remission, or the remissions are short-lived, usually a couple months, 3 months, 6 months. The probability of having a remission for 1 year, which would be wonderful, is only about 30%. So definitely a history of remissions and flare-ups, and remission and flare-ups. Risk factors for a flare-up is a concomitant bacterial viral infection, so gastroenteritis if you get the bug from the grandkids, or you get a bug from your brothers or sisters, that can set off your Crohn's. The use of NSAIDs, the use of antibiotics, not smoking. There's that House episode where he actually prescribed heavy smoking to his patient with ulcerative colitis, and Cuddy got all upset about that because, of course, you can't do that. Smoking's horrible in other ways, but heavy smoking does seem to prevent it. The catch, I think I took all these slides out, the catch about smoking, when you finally do stop heavy smoking, then you're at much greater risk than normal for a flare-up of ulcerative colitis. Psychological stress can cause a flare-up. Having ulcerative colitis in more than one region of the colon also increases the risk for frequent flare-up. Older in age, more flare-ups. Certain foods, again, dairy products, greasy, fatty foods, fiber, alcohol, and caffeine all increase the risk for flare-up. What's the risk for the dreaded colectomy, where it's surgically have to take a piece of your colon out? What's the story with that? About 24% of these patients will need colonectomy within the first 10 years. That's a big number, 10 years after they're first diagnosed. Approximately 30%, almost a third, will need colectomy within 25 years of the diagnosis. Interestingly, that first attack can be so severe that a colectomy is needed immediately. 10% of patients who have their first flare-up of ulcerative colitis will end up needing a colectomy because of that flare-up. Mortality rates have gotten quite a bit better. They used to be about 35%. A third of the people would die with this back in the 50s and 60s. But the glucocorticoid therapy and the surgical techniques and the antibiotics, the treatment we have for this is pretty good. Mortality rate is now under 2%. If mortality occurs, it's usually during surgery or after surgery for a colectomy surgery. And of course, older patients are more